discussing a case that many of us have probably encountered. A patient presents with myopic discs and suspicious-looking optic nerves. This is a case of a 50-year-old African-American female who was referred for glaucoma evaluation. This patient had been referred after a routine eye exam with their primary eye care provider and was referred because of the suspicious cupping in each eye. The patient had denied any history of ocular trauma and denied any history of ocular surgery. The patient reported that she was in good general health. Her only medical condition was Raynaud's phenomenon. This patient did report a positive family history of glaucoma, with her mother having the diagnosis. The visual acuities were measured to be 20/40 in the right eye and 20/30 in the left eye. This was with her spectacle RX. Pinhole did improve vision by 1 line in each eye. The spectacle RX was measured to be -18 in the right eye and -14 in the left eye. IOPs are measured to be 16 OU with Goldman tonometry. Optometry revealed pretty thin central corneal thicknesses, about 500 microns in each eye. Gonioscopy revealed deep angles. The angles were open to ciliary body 360 OU. This is the visual field that this patient took. As you can see here, the indices are pretty reliable on each eye, and both eyes show an inferior defect. Possible inferior ocular defect, especially over here on the left eye. The optic nerve head OCT here, I'll have you look at while I'm going over my optic nerve head assessment. So for the right eye, I graded the cupping at 0.6 and I noticed some superior thinning. I also noted temporal peripapillary atrophy and a tilted myopic disc consistent with her glasses prescription. Over here on the left eye, I did grade the cupping a little bit bigger at 0.7, and I noticed superior thinning and inferior thinning. This eye also had the same temporal peripapillary atrophy and a tilted myopic disc. At the bottom of the page here, you can see for the right eye, all the values are in the normal range, the retinal nerve fiber layer values. The left eye, some superior thinning being flagged here. At this point, I diagnosed this patient with normal tension glaucoma, mild to moderate OU, and I had discussed treatment options of topical therapy versus selective laser trabeculoplasty with her. We discussed the risks and benefits, and she had elected to proceed with SLT. At this point, I set the patient's target pressures at 12 OU, which was a 25% reduction from her baseline IOPs of 16 OU. This patient did very well with the laser procedure. After the laser, the right eye achieved a target pressure of 12, and the left eye had a pressure of 13, very close to the target pressure. This patient has been seen about every 4 months since the initial evaluation, and her visual fields and OCTs have been stable. Her optic nerve head evaluation has also been stable. Her IOPs have remained at or below her target pressure of 12 at each subsequent visit. Cases like this present a diagnostic challenge for the doctor because the patient's presenting with normal tensive IOPs. The myopic-looking discs also makes it more difficult to assess the cupping. In cases like this, it's very important to get a dilated fundus exam so you have a full stereoscopic view. And it's important to look at the superior and inferior rims. That's the areas that are the most vulnerable to damage in glaucoma. It's important to look for any rim thinning superiorly and inferiorly, and also any notching or saucering of the rim. In normal tension glaucoma, disc hemes are also more prevalent compared to in primary open-angle glaucoma. So you also want to be on the lookout for any disc hemes as well. It's important to also correlate your clinical exam with the diagnostic testing. For example, in this case, the visual fields show inferior defects in each eye, which correlated with the superior rim thinning on the optic nerve in each eye. The OCT of the left eye also shows some superior temporal thinning, which was consistent with the optic nerve head exam and the visual field. In addition, you also want to look at all the risk factors. This patient had multiple risk factors for glaucoma. She reported a family history of glaucoma, an immediate family member, which increases her risk of developing glaucoma as well. She had very thin central corneas. We know from the ocular hypertension treatment study that it's an independent risk factor, since CCT is an independent risk factor for developing glaucoma. In addition, the patient reported a history of Raynaud's, and that is a risk factor for normal tension glaucoma as well. Other risk factors for normal tension glaucoma include a history of headaches or migraines, history of sleep apnea, and history of anemia. This patient's high myopia itself was also another risk factor for glaucoma, and the patient's race, being African American, was another risk factor she had. So with all these things in mind, even if patients present with normal tensive eye pressures and suspicious looking optic nerves, it's important to look carefully to see if the disc is just tilted and scary looking due to the high myopia, or if it actually has cupping due to glaucoma. I hope that this was helpful. Thank you for joining us today.